most famous movies. This is Ingmar Bergman's movie from 1973, Szenen einer Ehe. I think the English title was the same than the German title, and it was the first movie in which controversies between couples had been expressed in a film. And I would take it as a basis of my argument, the pro part, in my mind, the male part, and the contra part, which is the female part, and you will see where we will end. So you've seen the meta-analysis, and to be honest, I'm not a big friend of meta-analysis, because meta-analysis is based on the quality of studies which are in the meta-analysis, and even there is a sophisticated methodology in our days. Meta-analysis always are dominated by the big studies. So this is a huge problem, and it's not very surprising that my pro-opponent showed the small studies and not the big ones, because in small studies, mainly one-center studies, things are sometimes much easier. I will show you 4 studies, the 4 biggest ones. And I will start with the pro studies. The first had been the pro-rata study by Jean Chastre's group in Paris, 1,300 patients screened, 600 randomized, 300 in each arm. And you have to be aware this is a study from 2010. And you heard about antibiotic stewardship. However, 2010 was before the area of antibiotic stewardship started. So this is a study in a more or less naive situation. And what they were able to show finally is, if you use a given PCT approach, and I will not go through the approaches during the rest of my talk, you see there is a reduction by 23% of antibiotic exposure. This is the same for all disease entities, more or less, pneumonia, abdominal infection, but also sepsis, and there's no difference in mortality. And this is very important to say in terms of hard outcome parameters. You are not able to show a difference. There is a difference in antibiotic exposure, and there is a hypothesis, and this has never been confirmed, that this will be followed by a reduction in multi-drug resistant pathogens. The second study, the de Jong study, is a very special study because it's a case control study. It's a study comparing intensive care units doing a procalcitonin approach to intensive care units who did it not, which is a little bit an artificial scenario, because you can never be convinced that the quality of care in different intensive care units is really the same, and that the patient population is really the same. And what came out of this study is, yes, there is a reduction in antibiotic exposure. Now it's not in percentage, but it's 1.8 days. And there is, for the first time and very surprisingly, a difference in mortality. However, there are 2 against studies. And the first is a Danish study by Jensen, published in Critical Care Medicine. Again, it's 2011. It's before the antibiotic stewardship area started, and what he showed was absolutely in contrast. He showed there is an increase in antibiotic consumption and no difference in mortality. And because he showed this increase in antibiotic consumption, more antibiotics independent from the class of antibiotic, he recommended not to use a procalcitonin approach. The last study is a study from the German SEPNET network. That's also a very specific study because it's a so-called bifactorial design, which meant two different approaches are studied in one study, the administration of Selene on the one hand side and the procalcitonin approach on the other hand side. And to be honest, a bifactorial design is only possible if the two studied approaches do not have anything in common in terms of outcome parameters. I personally find this is not the case in this study. Both approaches are influencing themselves, and so a bifactorial design is not possible. It's a huge study, close to 1,200 patients randomized, and please look to the cartoons. Finally, for the procalcitonin approach, there's no difference in mortality, and there's also no difference in antibiotic consumption. In contrast, if you look to the antimicrobial free days in the ICU, there are more free days in the conventional arm than in the procalcitonin arm. So you are confused. 4 studies, all are more or less well done, all have limitations, 2 on the male side, 2 on the female side. What is the difference between the studies? And the main difference between these studies, you have to look in which scenario they take place. And as I said, the French study was before antibiotic stewardship started. And if you look to the European landscape of antibiotic consumption, France was among the top 5. So before these studies started, a lot of antibiotics had been prescribed in French, not only in hospitals, but also in outpatient departments. So the chance to reduce antibiotics was a very good one. If you look at the same time point to the Danish study, the Danish are Protestants, Calvinists. To use drugs in Northern Europe, you need to be very, very severely ill. And Denmark is on the lower ranking of antibiotic consumption. So if you are good in terms of antibiotic consumption, you are on a lower level. If you have no resistant problems, what should you show in such a study? Nothing. And this is what had been shown here. And this is the same with the studies which came up. Yes, the Netherlands also is a low antibiotic consumption country. However, the design of the De Jong study, comparing intensive care units and not comparing an approach in the same environment, is something which can be criticized. And the German study has some limitations, but it is a study which is also in an environment which is used to use antibiotic stewardship, mainly in the Jena Center, which was the lead center of the German study, and they are up to do it in a professional way. So the conclusion is, if you have no experience in dealing with infectious disease, and if the standard of infectious disease management is bad, it's better to use a biomarker than to do nothing. But on the female side, if you know what to do, you do not need the guidance of a biomarker, which also has a number of limitations. And I do not want to focus on this limitation, but procalcitonin is an organ-specific biomarker, different levels in different organ systems. It's a difference whether it's intra-abdominal or whether it's pulmonary. It has no signal, for example, in endocarditis, and it has a huge signal in brain damage independent from infectious disease properties. So my final comment is, I'm a man and I'm in favor of women. So I'm in favor of being experienced. And my message is we should invest into infectious disease education in intensive care. A third of intensive care management is infectious. You do the same in mechanical ventilation.